Good morning. I'm Jenny Glenn Gingery. I'm the Associate Director of Communications and Media Relations at the Endocrine Society. I'd like to welcome you to our first of our ENDO 2019 news conferences. Today we're going to be talking about the latest science and advances in clinical practice in diabetes. We're pleased to have with us Dr. Derek Leroyth and Dr. Mark Molich, two of our authors of our brand new Clinical Practice Guideline on diabetes in older adults. We'll be sharing the recommendations from that today with you for the very first time. We also have, among our respected speakers, Dr. Anders Carlson, Dr. Gregory Goodwin, and Dr. Maria Chang Villacresis. So welcome to all of you. Over the next 45 minutes, each of our speakers will be discussing their work and sharing their findings. Today, because the guideline session is taking place at 9:30, we'll be presenting the guideline first. Then we'll have a brief Q&A with Dr. Leroyth and Dr. Molich. Then we'll have each of our other speakers speak, and we'll have a joint Q&A for those three presenters at the end of the session today. Please note this news conference is being broadcast online. Because there's so many journalists joining us on the internet, we would ask that you please speak into a microphone when asking any questions and clearly identify yourself. That way everyone can participate in the conversation. For journalists who are attending online, welcome. You can type your questions into the program at any time, and then we will field those during the Q&A. I'd now like to invite Dr. Leroyth to the podium.
Thank you very much, and I just have a few slides which will demonstrate a little bit of what we've done over the last couple of years and which are available to you as well. We're going to obviously talk about the guideline, and I just want to thank the writing committee. You can see that Dr. Mark Molich and myself are here. I should just mention that we are the two oldest in the group. One of the reasons that we both were happy to do this guideline, one mentioned specific ages, but you can see the list of the writing committee. A couple of key points that I think are important as an overview, and then we'll discuss further. It's very important to realize that prediabetes is very prevalent in older people. It's also been shown by a number of studies that you can actually delay the progression of prediabetes to diabetes, and is especially effective in this age group. As type 2 diabetes increases in the individuals with age, it also exaggerates the micro and macrovascular complications. And parenthetically, I think the importance of the guidelines are that for many decades, for many years, we've not really paid a lot of attention to the older individuals with diabetes because it was considered, well, they have a limited lifespan, but we now know that 65, 70-year-olds live until 85, 90, and so preventing the long-term complications are important, not just the short-term issues that they suffer from. We believe that there should be regular screening, because if you screen for prediabetes and diabetes in the older population, it then can allow you to intervene, so this is very important. They also have a lot of effects that affect older people as compared to younger people. We also believe that all the decisions in terms of management of these patients should be a team approach, and this will help tremendously. Many of the older individuals have problems with sarcopenia, muscle loss, muscle strength. They're more fragile, and of course they have cognitive dysfunction. And all of these lead to issues that are much more common in the older age group, such as falls, loss of independence, hypoglycemia, and other issues. And these, one has to pay particular attention towards these issues. And so the guidelines present the many of the studies, and in some cases where we don't have studies, we have expert opinion, and these are very important for therapies for glycemic control, hyperlipidemia, and hypertension. We also take into account the renal insufficiency that occurs both with aging and if you have diabetes, and how this would affect the pharmacokinetics and dynamics of the specific agents that we are dealing with. So both renal disease and cardiac disease are very important, and we've discussed that in these guidelines. These are the resources available to everybody, both the publication in the JCNM, as well as resources that you can find using the apps and the resource page as shown here. So at 9:45, we're going to actually present the guideline. We're going to have a panel discussion with cases to try and highlight the issues that I've just described. And I think what we'll do now is we'll open it up to questions and answers from you to us, Dr. Molich and myself. Thank you.
So we would just ask if everyone could speak into the microphone. Just a moment, we'll be bringing that out, and then we'll also be reading questions from the website.
It's okay. I'll stand. No, you want to stand? I'll sit.
Either way.
You like to stand? Okay.
Hi, Jody Godfrey from Endocrine Web. My question is if you would both comment on how the therapies for the older population might differ from those of the more general adult population.
If I can just, I'll let Dr. Molich discuss that, but we use the age of 65 as the cutoff. So we talk about 65 or older as being older individuals.
I think we specifically look at the characteristics of the individual patient and their abilities to give insulin, for example, their ability to test blood sugar level, financial aspects as well, and then look at the other things that may be going on with a person like that, comorbidities, heart disease, hypertension, and they may have cancers, other kinds of things that may cause problems for them. And so we sort of estimate how healthy they are. Are they a healthy older adult? Are they one with a very limited lifespan or something in between? And then we try to tailor the individual treatments towards those ends. One of the critical things is try to avoid hypoglycemia, low blood sugar level. If you have somebody who's 20 years old and they develop a low blood sugar level and they fall and hit the floor, they bounce off the floor. A 70-year-old who gets hypoglycemic and falls on the floor is going to fracture a hip. So we have to be very careful about avoiding hypoglycemia. Similarly, for blood pressure, we don't want to be too aggressive because, again, that can lead to falls. So all of these things kind of play a role in evaluating how to adjust medications for patients.
Do you have the mic?
Hi, Miriam Tucker with Medscape. I'm just wondering how these guidelines differ from those from other societies like the ADA and the AGS that came out a few years ago.
So we've updated the guidelines to some degree. The differences that have occurred that we've seen recently, there have been changes in blood pressure levels. And so whereas way back people would look at 120/80 as being very important, various societies are now looking at 140/90 as being a cutoff, below 140/90 being useful. So we've adapted from the data similar levels such as below 140/90, but again, as mentioned a moment ago, it depends a lot on the individual. So patients who have a lot of comorbidities, a lot of diseases, we perhaps won't go as low as we used to. So, there have been changes both in blood pressure, there have been changes in glucose management, hyperlipidemia, for example, at a very old age, we probably won't treat it aggressively. So there are differences that are coming about through a number of societies, and we've updated it to reflect that in many situations.
I think one of the other major areas that we've updated is relationship to some of the diabetes medications used for treatment of diabetes that have been shown to have cardiovascular benefit in the last few years, and those other guidelines hadn't quite gotten to that point. And so we've used some of the information that has actually come out from ADA in general for management of diabetes, for emphasizing the use of medications that have cardiac and renal benefit.
Sherry Rowan, Everyday Health. Can you comment on the differences in the guidelines regarding A1C testing and whether that's being de-emphasized in favor of different types of monitoring?
So actually, it's one of our cases that we're going to discuss, the question of hemoglobin A1C. In the older age group, the A1C is often fraught with inaccuracies. And so quite often we would prefer to our postprandial fasting glucose, not that the A1C has lost its flavor totally, but we have to take into effect that there are problems with the older age group, whether it's dilutional effects, whether it's kidney, whether it's hemolytic effects. There are a lot of problems that we sometimes encounter with the A1C. And so the glucose tolerance standard is actually very useful in terms of making definitive diagnoses. Would you agree? Yeah.
Looking ahead to what Dr. Carlson is going to talk about, to what extent do these guidelines address type 1, older adults with type 1 diabetes?
We actually do have a section on type 1 diabetes within the guideline, and I think in general there's not that much difference as far as our emphasis on what the glucose level should be, the avoidance of hypoglycemia, trying to avoid complex regimens, and especially as there may be some cognition problems as people get older. So those aspects are sort of emphasized in that. Many patients with type 2 diabetes are also on insulin therapy as well, so that there's a merging of the two with respect to insulin therapy.
And quite often you may consider how to measure the blood glucose, such as continuous glucose monitoring, etc. But again, this will depend on the patient itself. So it's a personalized medicine approach. And if they are capable or able to use CGM, it may well be appropriate. We always have to take into consideration their cognitive, their situation, financial and otherwise. But there are some similarities.
Any other questions? Great. Thank you so much, Dr. Leroyth and Dr. Molich. We appreciate you joining us today.
Thank you.
Great. I'd now like to welcome Dr. Carlson to the podium. He's the medical director at the International Diabetes Center.
Well, thank you and good morning. And I couldn't have been set up any better for this talk than just presenting the guidelines before. So thank you. What I'm going to show to you today are the baseline data from one of our randomized control trials, which should be reported later this year on hypoglycemia in older adults with type 1 diabetes using CGM. And as you just heard, the consequences of hypoglycemia, particularly in older individuals, can be devastating. Not only falls that can lead to fractures, but also arrhythmias and so on that can be quite devastating with additional comorbidities. Not to mention the enormous cost this has on our healthcare system. Patients who have long duration of type 1 diabetes, however, largely haven't been included in many clinical trials, particularly trials looking at technology. And so that's what we set out to do here with the Wisdom trial. And Wisdom is the wireless innovation in seniors with type 1 diabetes. And so I'm going to show you the baseline data for this trial. The goal here was to use CGM and look at their profiles in adults 60 and older. We use 60 as a cutoff. And look at patterns associated with glucose control, particularly as they relate to hypoglycemia. And this was done with blinded CGM using the Dexcom G4 system. And we collected baseline data as part of this 6-month trial. And we had an N of 203 subjects, all over age 60, with an A1C less than 10%. And I'll show you, but we aimed for a recruitment target of at least 40% pump and 40% MDI. And none of these patients had been on CGM previously in the last 3 months. So for our analysis, we looked at the CGM metrics from the sensor data and did regression models, specifically looking at factors such as age, sex, education, income, insurance, employment, living status, and so on, and also things such as duration of diabetes, insulin dosing, total insulin dosing, previous use of CGM in the past, and hypoglycemia unawareness. And then the analysis was conducted in a stepwise fashion. So here are the baseline characteristics of our 203 subjects. Average age was 68. Total median duration of type 1 diabetes was 36 years, about half female. 94% had some college or more. 53% were pump users, and then mean A1C of 7.5. And here was our primary result of the baseline characteristics of those 203 individuals. Time spent in hypoglycemia, defined as sensor glucose less than 70 milligrams per deciliter, was 5.0%, or 72 minutes per day, with time in a very low glucose, or what I would consider a dangerously low glucose, less than 54 milligrams per deciliter, of 1.6% of the time, or 24 minutes per day. When we broke out groups by awareness to hypoglycemia, so patients who were aware or reported that they were uncertain if they were aware, they spent time less than 54 of 1.3% of the day, or 19 minutes, whereas those who identified themselves as having reduced awareness had over twice as much time in the very hypoglycemic range of less than 54 of 2.7%. So 1.3% for aware and 2.7% for those with impaired awareness. Overall, the time in range for this cohort was 57%, or 13.7 hours per day, and this is defined as a time in target range of 70 to 180 milligrams per deciliter. And regarding hyperglycemia ranges, overall there was 35% of time spent in the greater than 180 range and 12% greater than 250. The coefficient of variation across the cohort was 42%. And in the subgroup analyses, looking at all of the different factors that were associated with the CGM metrics, very few of those factors that I mentioned before were associated with time in range. However, being retired did come out statistically significant for a higher time in range. Also, interestingly, household income corresponded with time in range, with those who had an income between $35,000 and $75,000 per year as having a lower time in range, whereas those in the group of less than $35,000 or greater than $75,000 had higher time in range. So it was somewhat of a U-shaped curve that was unexpected. Also, total daily dose of insulin, the lower that was, the more time in range there was. And everything else was non-significant. And just to kind of put this in clinical perspective, if we look at the Wisdom baseline data here, I can show you the time in different ranges. So time in target range, again, was 57%, with 5% less than 70 and 1.6% less than 54. And I just want to highlight, as this compares to the upcoming 2009 consensus targets, which have been presented and have yet to be published, showing that the time greater than 250 is less than 5%, greater than 180 is less than 25%, with a target time in range of greater than 70%. And specifically with regard to hypoglycemia, you can see that our subjects in this cohort of 203 older adults with type 1 diabetes are not meeting targets for hypoglycemia. They have more hypoglycemia than we would expect. So hypoglycemia is common in this group of adults. Those with hypoglycemia unawareness spend over twice as much time in a dangerously low glucose compared to those with intact awareness. And time in target range is associated with employment, household income, and total daily dose of insulin. So To conclude, we still strongly feel that hypoglycemia is a major barrier to optimal glucose control in type 1 diabetes. Hypoglycemia awareness is still a major issue and a risk factor for very low glucose. And at baseline, our adults here are not achieving the recommended time and target ranges. And so we await the full results of our randomized control trial, which should be presented later this year. And I'd just like to thank our participating clinic sites around the country as part of the T1D exchange. So thank you.
Thank you, Dr. Carlson. I'd like now to invite Dr. Gregory Goodwin to the podium. He's a senior associate physician at Boston Children's Hospital.
There's not a pointer, is there?
I don't believe there is, actually. I'm sorry.
Good morning. Switching gears to the pediatric and adolescent population, which is a challenging group from the get-go. I'm going to talk about implementing hybrid closed-loop insulin pump therapy, the Medtronic 670G, in a real-world or a regular clinical setting and not in a research environment. Just a reminder that standard pump therapy uses fixed doses of insulin, so a fixed basal rate, which you can see the line at the bottom of the graph here, and then fixed boluses of insulin for food and for correction. Now, this is the hybrid closed loop system joined with CGM, so you see dynamic changes in the blood sugar, much more data than you would see just measuring capillary blood glucose. So we want to see how this system works. Theoretically, it's brilliant, but we want to see how it works in the real world. A little bit about hardware. That's the Medtronic 670G pump. That's the sensor, the Guardian 3, and what a teenager might look like using the system. It was FDA approved in September 2016 for 14 and over, and in June of 2018 for 7 and above. So this study was conducted at Boston Children's Hospital. We basically allowed anyone to use this system who wanted to use it and had the approval of their treating physician and nurse educator. So we had 93 patients enrolled between May of 2017 and August of 2018. Their average age was 17. Their range was 5 to almost 25, and equally divided male to female. This was our outcome. In the first pivotal trial that was done where Medtronic obtained FDA approval, they had around a 5% dropout rate. And you can see here we had actually a 38% dropout rate over a variable period of time. Why are they not sticking with this system? Frequent alarms, what are called forced exit. Auto mode means that this is the artificial pancreas system where it's delivering insulin based on your glucose level. So what happens is this: if you don't fulfill certain requirements, if you're high for too long, it so-called kicks you out of auto mode and you're back to using a standard insulin pump. So there were a fair number of exits from auto mode, demands for calibrations, premature sensor failure, and just routine problems like skin reactions, non-adhesion, sensor supply problems. What you see here is you see the boxes on the graphs of these are the exits from auto modes where the patient is being, so you can get an idea of frequency of exits from auto mode. So the other interesting aspect of this study is we looked at the patients that remained in auto mode, how they did over time. So in the first 6 months, they had a statistically significant improvement in their hemoglobin A1C. However, between 6 months and 12 months, and 12 months and 24 months, that significance was lost. And I believe this is in the medical literature. We have some of the longest follow-up data on patients on this system. However, for those patients that were savvy and compliant with this system, if they remained in auto mode or artificial pancreas mode, for greater than 57% of the time, they showed significant improvement in their hemoglobin A1Cs. So summary, hybrid closed-loop insulin pump therapy is the most advanced technology available to treat type 1 diabetes. Correct use of this technology significantly improves glycemic control. However, significant challenges for many patients to fully implement technology. And we need more user-friendly technology for this to be available and practical for the average patient with type 1 diabetes. Thank you.
Thank you so much, Dr. Goodwin. And now I'd like to invite Dr. Maria Mercedes Chang Villacresis to the podium.
Okay, good morning, and thank you for the opportunity to having me here. I am going to present the results of our study group, and we titled this Underestimation of the Prevalence of Diabetes and Overestimation of the Prevalence of Glucose Tolerance by using the hemoglobin A1C criteria. So the elevated A1C, and just to have a little background, was first reported elevated in diabetics in 1969. And it was then started to be used as a surrogate marker for glucose monitoring, and it represents an average blood glucose of the 3 months prior to the measurement. And so it was first started to be applied to the diabetic population in 1976, but due to lack of standardization, it was not until 2009 that it was standardized. And then in 2010, it was started to be used by the ADA in the guidelines for diagnosis of diabetes and prediabetes. So as we see down here, the criteria from the ADA guidelines are diabetes when an A1C is more than 6.4, meaning 6.5 or above, and 5.7 or above is impaired fasting glucose. So we took the data from the NANES from the CDC from 2005 to 2014, and we calculated, we compared the results of the A1C criteria versus the oral glucose tolerance test and the fasting plasma glucose. So we found that from those people who were deemed normal glucose tolerance in the first row from the A1C, these people that were normal actually tested, 42% of them tested abnormal by the fasting plasma glucose and the oral glucose tolerance test, meaning that these 42% would have missed a chance for early intervention. And we did the same thing in terms of the criteria for diabetes. So we found that from those population, those people who were deemed non-diabetics by the A1C, 73% of those were found to be diabetics by the plasma fasting glucose and the oral glucose tolerance test, meaning again that these 73% would have missed an early intervention and early treatment. So with these results, we wanted to conclude that even though the A1C is the more used method for diagnosing and screening for diabetes and abnormal glucose tolerance, we recommend that we do not rely solely on this number, since it did overdiagnose glucose tolerance tests in 42%, and it underdiagnosed diabetes in up to 73% of this population group that we studied. So if you have a patient that you suspect highly and has high risk factors of diabetes, perhaps you should not rely only on the A1C and pursue oral glucose tolerance tests to further elucidate the diagnosis. Okay.
Thank you so much, Dr. Chang-Villacresis. And now I'd like to open it up for questions. And again, because we have people joining us online, please be sure to wait until the staffer comes to you with a microphone before speaking.
Dr. Goodwin, do you have recommendations for making the hybrid closed loop more user-friendly?
Oh, and Jill, could you give your name? I'm sorry.
Jill Roulette, Endocrine Today.
Sure. To make it more user-friendly, they have to decrease the frequency of alarms and decrease the frequency of exits from the auto mode. It's just too demanding on the patients, and in order to be successful at this, it's really a full-time job to keep yourself in target. So number one is start with what I just mentioned. Okay, thank you.
Jody Godfrey, Endocrine Web. Dr. Carlson, could you comment on, from what we know at this point about the older population, what clinicians are supposed to do to address the whole unawareness of their hypoglycemia?
Right, so I think historically the recommendations to restore awareness were to avoid hypoglycemia. And so one way to do that has been to aim for higher A1C targets, or sort of relax glucose control, or try to use therapies that don't have as much hypoglycemia associated with them. And it's been shown that a higher, aiming for a higher A1C does not translate into less hypoglycemia. So I think our current strategies have not been successful, or as successful as we'd like them. With technology like CGM, where you could have alerts set up or have family follow the CGM, I think you'll see that we might be more successful at avoiding hypoglycemia, or at least minimizing the time of it, thereby restoring awareness. But again, CGM isn't very well studied in older individuals, and up until recently, just from a reimbursement point of view, older individuals were not offered, or available. The technology wasn't available to them through insurance.
Sherry Rowan, Everyday Health. Dr. Villacresis, can you comment on how common it is for physicians to use an A1C test for screening? I mean, is this a common practice, and does your study then indicate maybe a need for changed guidelines?
Thank you. Yes, so it is a very common practice, and because of its convenient use, the convenience of its the laboratory test, the way that it's done, it has become nowadays the primary method of screening and diagnosing diabetes. And yes, maybe, and actually the ADA guidelines do have statements regarding the use of oral glucose tolerance tests and not relying solely on the A1C. But we wanted to bring this up to emphasize that this gap between the diagnostic sensitivity between the tests is very important, and the clinicians shouldn't rely only on the A1C. And I think majority of endocrinology practice is aware, but because nowadays primary care physicians are also managing a lot of diabetes, it is important to bring this up as a alert for them too.
Kristen Monaco, MedPage Today. My question is for Dr. Goodwin. If you have a patient who isn't great with the system and gets kicked out of auto mode a lot, would you still recommend that they use the system? Will they get some sort of benefit, or would you just recommend they not use it at all and avoid it?
In sort of answering your question as well, there is a new sensor available that has less frequent forced exits from auto mode, so I think I would have them try the new sensor and see how that goes. I do think hybrid closed loop insulin delivery systems is the future. This is the first generation. It will improve with time. So I would encourage them to stay with the system, but if I really go by what they want, and if they give up, most of the patients I showed that withdrew, they completely withdrew. It was 100%. So I think it's the future, and but we need better systems.
A quick follow-up question. Do you think, so it's only approved for ages 7 and up, do you think in the future this might be used in a younger population?
Yeah, we actually used it in a 5-year-old and a 6-year-old, so it sort of depends on it's at the discretion of the treating physician. We've not used it in less than a 5-year-old, but there's no reason why it shouldn't work.
Thank you.
Any other questions? Okay, we actually got a couple online from some reporters that are covering remote. The first one is, what technology could help type 2 diabetic patients help type 1 diabetic patients? And this is from the Brazilian Endocrinology and Metabolism Society.
Who's it directed to?
Yeah, I'm not sure who that one's directed to. Yeah, it doesn't say who that one's directed to, so maybe Dr. Goodwin or Dr. Carlson can answer that one.
I mean, I can take a stab, but that could fill a conference of its own of the technology that can help type 1 and type 2 individuals. But I would say where the field is going, I think, is absolutely right. I think automated insulin delivery is definitely going to be the future for type 1, but particularly for type 2. I think we'll start seeing that more and more as a viable option. But of course, sensors need to get better. The integration of devices with each other and how they can maybe perhaps be interoperable will be a major step forward. But again, our data from the U.S., even in the T1D exchange, pumps and sensors are becoming more prevalently used in folks with type 1 diabetes, but still only about half adopt the technology. And I think there's a chance we could leave some folks behind if we don't address socioeconomic gaps, gaps in care, care delivery models, education. I mean, all of those things need to be in place as well, despite the technology being as advanced as it is.
Very good. I think we have one other question here. This one is for Dr. Villacresis. Could you please elaborate on the racial and ethnic differences involved in your study?
Yes, so the data was extracted from the NANES from the CDC from 2005 to 2014. And we found that the sample was very representative. So the mean age was around 48 years. and about half of them were females. Also, the racial differences, and I'm not sure if they are talking about the difference in the sensitivity of the test that we also saw, but we saw that our markers were less sensitive for Hispanic groups, which is interesting to observe, but we don't have an answer for the explanation as to why.
Great. I believe Jody has a question up here.
Oh, sure.
Jody Godfrey, Endocrine Web. Dr. Carlson, could I just ask for a follow-up? I'm kind of curious with the talk about going to more CGM with type 2 diabetes. Is that because there's just been a complete failure of earlier intervention and lifestyles just people are not willing to make the changes, and so we're getting them sicker and then they have to be on machines as opposed to addressing it earlier and having them in remission?
Sure. So I think in type 2 diabetes, it's tough to know which comes first. I think, we're seeing the rapid expanse of flash glucose monitoring for sure, and even with some real-time systems as well. It's probably a little bit of on both ends. I mean, I think there's some more engagement that you can have with patients. I have patients now who are on a Freestyle Libre who are scanning 20, 30 times a day to look at their glucose, where previously maybe they checked once a week. And so it engages them in their lifestyle and behavior and sort of their daily management on their own, rather than waiting 3 months to come see me to download or look at a logbook of 1 or 2 blood sugars a week, which isn't altogether that helpful. So I think there's some empowerment that CGM is allowing patients to have in managing. I will say that in 10 years of practice, I can't think of a time when someone came to me and asked, "Please give me this blood glucose, finger stick meter, please." And now we're getting those questions. So I think there is more just awareness out there about it. And then I think on the opposite end, we need to put into place ways to teach physicians and nurses and the whole care team how to use this data. I mean, it's great if you can have it and it's at your fingertips, but unless we know what to do with it and know how to talk to patients and make recommendations and how to adjust therapies, it's just another new thing, shiny new thing that may not be worth the expense. So I think kind of on both fronts we have to do better. Yep.
Great. Any other questions? All right, I think we're going to wrap up for today. Thank you again for joining us, and thank you so much to our speakers.